Good evening. Welcome to Ask Me Anything. Tonight we answer your questions to help you become heart attack proof. For those that don't know me, I'm Dr. Twyman. I'm a board certified cardiologist, the owner of Apollo Cardiology, and my practice focuses on the early detection of subclinical atherosclerosis, in English, which find plaque before you have your heart attack or strokes, and we help you prevent those. So if you're ever interested in potentially working with us one-on-one, we still do accept new patients. We are booking out 2 to 3 months in the future. So if you go to my website, drtwyman.com, there is an application, and my team will discuss it with you if you're interested in working with us. So there are a few questions that got submitted ahead of time. So every Monday morning, I put it in my stories. That's where you submit your questions, we answer them live here. And if there's time available, and there usually is, you can also drop a question in the comments, and I'll answer them there as well. All the archives of this generally stay on Instagram for 1 month, so there's always replays, but after a month they kind of do disappear for a while in the feed. So I do take these and drop them onto my YouTube channel. YouTube channel is just drtwyman.tv, and I do have some longer form videos there as well. But if you're looking for the most up-to-date long form videos, those live in my school community. There's a free 7-day trial. The school community is where I utilize a lot of interesting AI tools to help generate some of the content from my previous over 60 podcasts I've done. So concise summaries, infographics. I actually did record a podcast today that was more about quantum biology and circadian biology, topics that I know but don't always frequently talk about on podcast. So if you're interested in hearing things about quantum biology, there's a new podcast that just got dropped in the school community. So first question tonight. How much vitamin D does a 69-year-old woman need? So vitamin D is a hormone. I generally recommend from a vascular standpoint to shoot for a level near 60, and that's 60 without oral supplementation. There are some conflicting studies. The VITAL study started a few years ago. It was using fixed dose 2,000 IUs of supplementation that did not show any improvement in cardiovascular outcomes in patients who supplemented. There was later studies. The study was done in patients who had heart attacks, and they were looking to see would they have repeat heart attacks. This time they actually treated to blood levels between 40 and 80 micrograms, and they were using doses of 5,000 IUs and higher to get there. But I generally still recommend patients focus on sun exposure. The UVB light sulfates the cholesterol in your skin, turns it into vitamin D. So shoot for a level of 60. Next question tonight. Does VO2 max give an indication of cardiovascular health? Yes, it's a marker of cardiovascular fitness. The higher the VO2 max, the more aerobic capacity the person has. Is it the be-all end-all for longevity? No, but think of VO2 max as sort of like your hemoglobin A1 for exercise. You cannot get a VO2 max by biohacking or just working hard for a week or two. This is something that you build over many years generally. So it's a marker of your cardiovascular fitness, and you generally would like your number to be at least average for age, but ideally higher than your age or average for your age. Does calcification have an effect on VO2 max? By this question, I would anticipate the question is coronary calcifications, because calcifications of valves would not likely have an effect. Generally won't affect VO2 max unless it's causing you to have angina, chest pain, or shortness of breath, where you stop the activities before reaching VO2 max. So typically you do have to do more interval type training or zone 5 training to boost VO2 max. So calcifications would only be an issue if you have severe coronary stenosis, generally 70 to 80% stenosis, but otherwise no, should not have an effect. And then the last pre-submitted question tonight was, what can be reasons for LPLA increasing? So LPLA, for those that don't know, is the number one genetically inherited lipoprotein that increases the risk of early cardiovascular disease. Everybody has lipoprotein A. It's similar to LDL, but it's more thrombogenic and atherogenic, meaning it's more likely to cause blood clots, more likely to cause plaque or blockages in the arteries. So up to 20% of the population has elevated serum levels. Some reasons LPA may increase is if there's a lot of inflammation, LPA will increase. So there's a couple blood tests that I routinely check in patients with high LPLA, oxidized phospholipid ApoB, LPPLA2 activity, and interleukin 6. If those markers are elevated, LPA often is increased with it because LPA is a marker for how much inflammation is in the arteries already. If inflammation is low, LPA generally goes back to your genetic set point. Other reasons LPA may increase in women is when they go through perimenopause and lose estrogen. The withdrawal of estrogen oftentimes will have an effect on LPA and cause it to increase. Those are the pre-submitted questions. So let's see if there's any questions dropping in the comments. Not seeing anything just yet. And for those that just joined, did want to let you know I did record a quantum biology mitochondria more focused podcast today. I don't know exactly when she's going to release it, but I did use some transcription software to create a summary for it. The summary is currently up on my school community, which is drtwyman.com/school. There is a free 7-day trial, so check it out if you're interested. If you want to stay around longer, there's a ongoing fee, not very much, but that's just so that we can keep it kind of more private, and also that then we can do other things with more one-on-one ask me anythings. And then we also have a lot of AI tools that we're utilizing, and those sometimes have some fees, so using those membership fees to upgrade the education experience for those that want to follow along in the community. So see, still not seeing any other questions just joining, so maybe a relatively short night for you guys checking this out. But if you want to see some of the old archives, my YouTube channel, drtwyman.tv, has hours and hours of YouTube videos that have summaries of what we discuss in these Q&As. Been doing these Q&As since 2020. So look for it. If you look for a topic, you can usually search for it on my YouTube channel. I do see one question here about an LPA therapy. What are my thoughts on niacin for LPA? Something that I used to look at a little bit more routinely in the past for patients, but there's really no great studies that using niacin to lower LPA has any outcome data, meaning LPA also rarely lowers very much, but niacin, maybe 10, maybe 20%, but generally the trials have shown that to have an effect, you probably have to lower LPA 85, 95%. So kind of fell out of favor, at least in my opinion, for trying to lower LPA. I think it's more worthwhile to lower ApoB through other means and just keep oxidative stress and inflammation low. The other challenge with niacin for LPA is using the right form of niacin. If people use flush-free niacin, it will not work. You have to have the flushing version of niacin. That's how it works in the liver, by creating these prostaglandins that cause the flushing sensation. And then to really get at any effect of lowering LPA, you're usually pushing, near 2,000 milligrams of niacin. That's sometimes very hard for people to tolerate. We also got to monitor liver function tests because high dose niacin can effectively. So again, work with your providers, but that's something I usually routinely recommend for my patients with LPLA. All right, guys, short and sweet, 10 minutes or less. And we'll see you next.